Success rates in solid organ transplantation continue to rise. Yet each measure of success brings with it a new set of challenges. Signaling the future, targeting co-stimulatory pathways. The quest to improve long-term outcomes begins with an exploration of the initial cascade of events that occurs within the immune system. Once an organ is transplanted, the body mounts an immune response against the allograft. T cells, which mediate the immune response, require two signals for full activation. Signal 1 is mediated through the T cell receptor's engagement with the antigen presented by the MHC on the APC. Signal 2, the co-stimulatory signal, results from receptor-ligand interactions that occur between the T cells and the APC. This co-stimulation enables T cells to proliferate and mount a sustained response to the allograft. Although current immunosuppressive therapies, such as calcineurin inhibitors and mTOR inhibitors, work to prevent T cell activation and/or proliferation, their targets are not specific to the immune system and may be associated with therapy-related toxicities that may compromise long-term graft and patient outcomes. To meet the current challenge of reducing toxicities and prolonging graft and patient survival, selective agents are needed. While multiple pathways are currently being investigated for the development of immunoselective agents, CD28 is one of the best characterized receptors required for co-stimulation. By preventing CD28 from interacting with CD8086 on the APC, signal 2 is blocked, and the T cell is rendered anergic or apoptotic. Since CD28 is expressed predominantly on T cells, this pathway offers the potential for immunoselectivity, possibly reducing the toxicities that may be associated with less immunoselective agents. Co-stimulation blockade via inhibition of the CD28 pathway is a therapeutic approach with the potential to improve long-term graft and patient outcomes, and one that warrants further investigation. At Bristol Myers Squibb, our commitment to research continues in an effort to advance the science of solid organ transplantation.
The use of immunosuppressive therapies in patients with kidney transplants has reduced the incidence of allograft rejection. The current standard of care immunosuppressive therapy includes calcineurin inhibitors, such as cyclosporin, plus anti-proliferative drugs, with or without maintenance glucocorticoids. However, calcineurin inhibitor-based regimens may not adequately preserve allograft function. In this 7-year extension of a previously published 3-year randomized trial, investigators compared the ability of Belatacept and cyclosporin to preserve allograft survival and function. Belatacept is a fusion protein composed of the Fc fragment of human IgG1 linked to the extracellular domain of CTLA4. It blocks T cell co-stimulation, thereby selectively inhibiting T cell activation. 666 patients who had received a kidney transplant from a living or deceased donor were randomized to maintenance treatment including a cyclosporin-based regimen, a less intense Belatacept-based regimen, or a more intense Belatacept-based regimen as primary immunosuppression. All patients received basiliximab induction and mycophenolate mofetil and glucocorticoid adjunctive maintenance therapy. At the end of 7 years of follow-up, the Belatacept regimens were more effective than the cyclosporin regimen. The estimated rates of death or allograft loss were about 22% in the cyclosporin group and about 13% in each of the Belatacept groups. The estimated glomerular filtration rate was also higher with Belatacept than with cyclosporin, suggesting that Belatacept may be less nephrotoxic. The cumulative frequency of serious adverse events was similar across all 3 groups. Thus, treatment with Belatacept as compared with cyclosporin reduced the risk of graft loss or death after kidney transplantation. Full study results are available at nejm.org.
This program is brought to you by Emory University.
Fundamentally, the drugs that we use today are very similar to the drugs that we've used since the 1980s. 1983 was the drug that revolutionized transplantation. Cyclosporin was introduced. Since then, that class of drugs, another drug very similar to it, have been the cornerstone, the foundation of immunosuppression. So it's been since 1983 since we've had a new drug that has formed the foundation of transplant, preventing transplant rejection. The first drug that we started to work with was CTLA-4Ig. That was that fusion protein that blocked the immune system. And that proved to be very effective in experimental systems in mice. Short courses of that treatment could lead to very prolonged survival of mouse transplants in mice. Of course, what we really wanted was a drug that was effective in people. And so we began to explore that same drug at the Yerkes Primate Center. And in those experiments, we were very disappointed to find that that drug, CTLA-4Ig, had really minimal effects in preventing transplant rejection. So that led to an effort to really understand the biology a little bit better and to see if we could come up with alternatives. So again, working with scientists at Bristol Myers, Peter Lindsley and Robert Peach, we started to understand how effective that drug was at blocking the immune system. Did it bind tightly enough to block the immune system? And it turned out, in retrospect, it didn't bind very tightly to the target that it needed to. And so an effort was undertaken to see if we could introduce mutations or changes in that drug to change its binding characteristics. And it turned out one of those, called LEA29Y, which subsequently became Belatacept, bound much better to its targets. And so at similar doses, it would have 10 times the effect in vitro or test tube studies. And it was that drug that we went back and tested in the primate. And there, the effects were much more marked. And so it appeared that it could be an alternative to the cyclosporin class of drugs. So Belatacept was a second generation version of CTLA-4Ig. The cells of the immune system that cause rejection are called T cells, and they need to get two signals to become activated and cause that immune response. They need to recognize things as foreign. That's the T cell receptor. And then they also get the second signals, which we call co-stimulatory signals. If a T cell gets both of those, it'll expand, divide, and attack the transplant. If you deprive the T cell of those co-stimulatory signals with a co-stimulation blocker, that's what Belatacept is, then it'll get the recognition signal, but not the second signal or co-stimulatory signal. And then they won't become fully activated. In fact, most of those T cells will go on to die. And so that allows us to prevent the immune response specifically to the transplant.